The things that I think creep up are things that unfortunately are quite common, and that's hot flashes. I've had patients say that those are just overwhelming and they want to go off therapy because of it. Unless you're somebody who does this all the time, this is not something that you're going to look at unless a patient complains to you. So I think talking about pharmacologic management as well as lifestyle management of hot flashes, and I think that lifestyle management issues are equally as important.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about androgen receptor inhibitors and antiandrogens. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back, and thanks again for joining us, Mo.
Oh, thank you for having me. I always love this.
So to start off, let's kick things off with a brief overview of the history of androgen receptor inhibitors and antiandrogens in the field of oncology.
Sure. This is one of my favorite classes of drug, these endocrine manipulations, because they are so logical. I always think of antiandrogens in the spectrum of prostate cancer. I think that's probably the best way to tell the history. It was in the 40s that it was understood that androgen is a driver in many, many cases of prostate cancer. And so two researchers, Huggins and Hodges, realized that if you caused a suppression of testosterone, you would actually have a decrease in metastatic disease in men with prostate cancer. And the way that they did that was either orchiectomy or estrogen, no longer done because of the cardiovascular risk. But from that time, ways to suppress testosterone to castration level, called now androgen deprivation therapy, is the cornerstone of the treatment of prostate cancer. Interestingly, it is seen that even when you cause castration levels of testosterone, disease can progress in some individuals, and that therefore there was development of other strategies to decrease the impact of androgens on prostate cancer cells. And so that led to the development of what was once called antiandrogens, or now androgen receptor blockers, which we use, and also the drug abiraterone acetate, which decreases androgen synthesis through inhibition of CYP17. So really, what you have seen develop over time is a logical way to decrease the impact of androgen in stimulating prostate cancer cells.
Wonderful. Thanks for that summary. Can we talk a little bit more about maybe the precise mechanism of action that each of these kind of classes of drugs are associated with?
Let's start with the androgen deprivation therapy. So the androgen deprivation therapy is either orchiectomy, which we tend not to use as much anymore, LHRH agonist, meaning that they act like LHRH, and we're going to talk about that in a bit. And then now LHRH antagonists are taking an increased role because we now have an oral drug that is an LHRH antagonist. I'm sorry if I'm going to do a little bit of physiology here, but
that's okay. I'll hold on. I'm ready.
So think of the fact that the hypothalamus produces luteinizing hormone releasing hormone, also called gonadotropin releasing hormone. So the hypothalamus stimulates the pituitary that causes luteinizing hormone to stimulate the testes to produce testosterone. In adult men, 95% of androgens come from the testes. LHRH agonist would therefore stimulate the production of testosterone. And it does. So when you give an LHRH agonist, you initially have an increase in testosterone, but over time, you cause a decrease in the ability of the pituitary to produce luteinizing hormone. Therefore, you get decreased stimulation in the testes to produce androgens. So when you think of an LHRH agonist, by continual use, what you do is get an initial surge and then a decrease overall if patients stay on the drug. And so LHRH agonist, leuprolide, gocirolin, triptorelin, those are agents that are agonists. LHRH antagonists have a direct effect to block the receptor and decrease release of luteinizing hormone and follicle-stimulating hormone, ultimately decreasing testosterone. LHRH antagonists don't have that surge of testosterone. They have an immediate effect of decreasing testosterone. Those are the two big ways when we're talking about androgen deprivation therapy. When we're talking about those other agents, the androgen receptor blockers block the androgen receptors on the prostate cell, including the prostate cancer. And then, as I mentioned, abiraterone acetate blocks the synthesis of androgen by blocking an enzyme. Too much pharmacology?
No, I think I stayed with you. I had very focused, but I'll speak for myself. Any of these physiology concepts that have that sort of negative feedback cycle, I have to stay very focused to make sure I'm following it all the way. But I think you explained it very well. So thank you for that, giving me clarity on how those therapies work in different ways, but ultimately provide the same outcome. Can we talk a little bit now, and I know you've given some examples, but in a more focused way, what are some primary, whether it's subclasses or examples of agents in these different classes, and what are some of the newer agents that we're seeing, and maybe we're seeing more or becoming more familiar to us?
When we're talking about LHRH agonists, those agents have been around since around the 80s, I think, and those are the ones that are leuprolide, gocirolin, triptorelin. Head-to-head, they've never really been compared in prostate cancer. They're considered to be equally efficacious. Some of the differences is how you give the drug, whether it's IM or sub-Q, depending on the product, and so also in how often you give the drug. In terms of the LHRH antagonist, we've only had one drug for a while that's an antagonist. That's daguerreolex. Recently, there was the approval of relugolix, which is an oral LHRH antagonist. And that has shown to have great effect in a non-inferiority trial in terms to the LHRH agonist. And also, there's some benefit with decreased cardiovascular risk with that drug. So I think this is a drug we're starting to see more and more. In terms of the anti-androgens or the androgen receptor antagonist, what we tend to think of is the first generation and the second generation. And the first generation, depending on how old you are, you may remember things like flutamide. We still use baclutamide every once in a while because of that surge we get when we use an LHRH agonist. We'll use baclutamide to block the receptor so that it won't get stimulated by that surge of testosterone. And then there was a drug called nalutamide. The agents we use now are enzalutamide, apalutamide, and darolutamide. They are full antagonists. The first generation, if you use them for a while, they could become agonist, actually. They could stimulate the receptor. And so the development of these second generations mean that they're full antagonists. They do cross the blood-brain barrier. So there's CNS effects with some of them that you don't see with the other agents, but that's a separate class.
So let's talk now a little bit more about some of the toxicities or adverse events that we see associated with these androgen receptor inhibitors or antiandrogens, both maybe as individual agents, if there's something unique to a specific agent, or just as the general subclass. Can you talk a little bit about those toxicities and what we should watch for?
So the first thing I really want to talk about, and this is the thing that I think gets a little bit under noticed sometimes if you don't work in prostate cancer. When you give androgen deprivation therapy, whether it be surgically or whether it be medically through drugs, you're shutting off those androgens. And there are both short-term and long-term effects to that. The short-term effects, or the acute effects, is better than short-term. The acute effects are things like hot flashes and loss of libido, fatigue. And so those are things that are very bothersome to individual patients. The other thing that I think about a lot, that because I feel that it doesn't get evaluated always as closely as it should, is the long-term risk, things like osteoporosis. Bone health is a huge issue in these individuals. And then there's the metabolic syndrome that you can see that can occur, increase in cardiovascular events, increase in obesity, insulin resistance, alterations in lipids, increase in diabetes. So when you tend to think of individuals with prostate cancer, I tend to think of them as being a little older, and those are often individuals that have comorbidities that may go a little bit out of whack because of the androgen deprivation therapy. I'm a really big one for really making sure that we monitor and address the impact of androgen deprivation therapy. Of course, talking about specific agents, there are toxicities associated with those specific agents. The agents that cross the blood-brain barrier, those antiandrogens, such as enzalutamide and to a little bit lesser extent, apalutamide, you have a slight increase in seizure that people will talk a lot about. Fatigue is something that you see a lot as well. So it's very dependent on the agent what some of the other toxicities are.
Thank you for that summary. And it just strikes me as, again, this is a class of drugs used not exclusively, but predominantly with the prostate cancer population. And depending on where our patients are receiving their care, whether they're still with their urologist or if they're doing their care exclusively with their medical oncologist, and just understanding that as a nurse, thinking of myself as a medical oncology nurse, if I'm working in a generalist practice, how many patients am I seeing that have prostate cancer? And then just being very intentional about understanding that when you think of classic, chemotherapy side effects, and we put those in one bucket, that's not all we're talking about here. And so when we're educating our patients, we're talking about their therapy, and no, this is not chemotherapy in the sense that patients usually perceive. So yeah, you don't have to worry about maybe some of those side effects that people always go to when they consider treatment for cancer. But as you said, these are still things that are significant and almost sneakily so, like they kind of sneak up on patients. It's not something that they wake up one day and have this horrible side effect or toxicity, but it can kind of creep up over time. And so I think it just highlights to me the importance of clarifying with patients as we introduce them to this therapy of this is very different than maybe what you've heard other people have had as far as treatment for their cancer. But these side effects and these toxicities to watch for can be equally concerning. So they have to still be elevated and emphasize the importance of watching for these things and tracking these changes over time.
I can't agree more.
So let's talk a little bit about that management. Are there pharmacologic strategies or treatments that can be used to either prevent, manage, or mitigate these toxicities?
I would say yes and no. So yes, some of them, I think there are really nice, clear guidelines out there. We know a whole lot about osteoporosis. And so there are kind of great guidelines that need to be implemented. And those guidelines are things from monitoring as well as instituting lifestyle changes for patients to decrease risk of osteoporosis, talking about smoking cessation, decreasing alcohol and caffeine, weight-bearing exercises, things that I think are really important simply for the fatigue as well, calcium and vitamin D. And then, of course, we have agents that we can implement when needed, denosumab and the bisphosphonates. And so I think having a nice strategy within your practice about monitoring, when to implement, and education is essential. The things that I think creep up are things that unfortunately are quite common, and that's hot flashes. Those hot flashes, I've had patients say that those are just overwhelming and they want to go off therapy because of it. And I think that we don't look unless you're somebody who does this all the time, this is not something that you're going to look at unless a patient complains to you. So I think talking about pharmacologic management as well as lifestyle management of hot flashes, and as a individual that has had them, I think that lifestyle management issues are equally as important. But whether patients need gabapentin added or maybe an antidepressant. And again, looking at risk benefit of the antidepressant you use. So putting somebody in an SSRI, if it decreases sexual function, then maybe that's not the best choice. So working individually with that patient and sometimes with their primary care physician, optimize that treatment. The other thing that I will say that I think is very underestimated, but more common than I would prefer, is fatigue. I'm going to call out all those wonderful papers in the literature, the guidelines from NCCN that really give a broad spectrum approach to assessment and management. Pharmacologic methods are certainly there, but fatigue is not giving somebody iron because it's not always iron deficiency anemia that causes fatigue. It may be sleep disorders with hot flashes. It may be decreased physical activity. So I think that we really have an opportunity as a healthcare team to together work on something for each patient to make their quality of life better as we're treating their disease.
Absolutely. I agree with that completely. And I think, again, it strikes me that if we're teaching our patients about these side effects. And, you know, as we're talking about them, hot flashes, if you've not had them, it's like, that's not a big deal. I can manage a hot flash. But if they're really bad, or you have your first one, you realize I can't manage this, or this is really disruptive to my quality of life, I think it's important to set that up front with patients at that stage of these could happen. And if they're significant and they're bothering you to the point where it's, you know, impacting your quality of life, that it's important for them to communicate that back to the healthcare team, because there, as you said, there are sometimes pharmacologic and non-pharmacologic things that can be done, but we don't want patients to walk away thinking like, well, it's not going to kill me, so I guess I just have to deal with it. Like there's somewhere in between that we can hopefully get these patients to where we can't maybe promise that we'll eradicate them completely, but there is means to try and manage them better. And so informing patients that any symptom or toxicity that they find they're having from these therapies, they shouldn't assume they just have to deal with it. Like there are things that we can recommend and try to work with them to optimize their quality of life, as you said. Let's talk a little bit now about the administration considerations that nurses should keep in mind when patients are being prescribed these androgen receptor inhibitors or antiandrogen therapies.
I think one of the biggest challenges I hear with the oral agents is how to take them. And it depends very much on the agent, if you need to take it with food or not with food, or it doesn't matter. And so one of the things that I do when anybody is going to go on one of these agents is I do a drug-drug interaction check to see if their other medications need to be separated or that kind of information. I think this is a nice time to call out the uniqueness of abiraterone acetate, which is always given with prednisone to help decrease some of the side effects associated with the drug. It decreases the mineralocorticoid excess that can happen and the adrenocorticoid insufficiency. So you have to look at the prednisone with it. The other thing with abiraterone acetate, it is recommended by labeling to take on an empty stomach at least an hour before, 2 hours after a meal. But there is data that you can use a lower dose with a low-fat meal. And so you will see many providers providing a lower dose, often to get around the cost issue, sometime around the pill burden, and that needs to be taken with a low-fat meal. So I have patients who are on the lower dose. We've talked about taking it with a low-fat meal. The specialty pharmacy has talked about it. And then they read stuff that's online or in the literature, and they're like, oh, I shouldn't be taking this with any food at all. So it's really important to make sure that you educate patients how to take the medication and warn them if there's different instructions out there than what you're giving. This is one of the drugs that I've seen this happen with a lot. What is a low-fat meal? What's a high-fat meal? We talk about this in clinic quite a lot. So I think helping people understand what a low-fat meal is, you know, and that it's not taking it with bacon. My favorite way to take any medication, of course, is with bacon. But like
with bacon, right? I mean,
those kind of conversations people need to know to make sure they're taking these medications so that they get adequate concentrations, so they get the benefit. So this isn't just because we think they should take this for like a 1% change. It can significantly change how the drug is absorbed. I think that's my big counseling tip. Know what your specialty pharmacy is telling your patients. Make sure your patients understand that and reinforce it over time.
Absolutely. And I think, again, you bring up a great point. I'll highlight is that many, if not all of these drugs are given through a specialty pharmacy, which adds a good intentioned layer of somebody else talking to the patient about what their drug is and potentially how they should take it. Again, they're trying to communicate, provide information, but that also is just another risk point for confusion for the patient. Understanding, you know, I'm told one thing from my care team. Hopefully you're hearing the same thing from your specialty pharmacy, but just encouraging your patients to always kind of come back to you as the healthcare team as the source of truth if there's ever any confusion about what they're maybe being told from the specialty pharmacy. And then, of course, if you add the layer in of the health insurance and their kind of care coordinators that sometimes show up on the scene, it just gets very busy. And so it's a nice point to remind patients that not that those people are giving bad or wrong advice or doing something, like they're trying to help too, but it's always important for them to remember and to trust that let's be the source of truth for those patients as they navigate those medication changes, potentially dose changes. Always important to remember, like if they have a question, always come back to us as the healthcare team and we'll try to help sort out if there is any points of confusion.
And I will tell you that one of the things that we have done in the practice I work with is we've worked really closely with the specialty pharmacy at our institution, phenomenal resources, like phenomenal pharmacists. And we've worked with them so that we do say the same thing in the same way, because, you know, the way I say it may be a little bit different. And I'm just amazed at how people hear things. So I've been really happy that it's mainly through these drugs that we have collaborated to really make sure that we're consistent. And I love that they give information and that I supplement it because I think people benefit from hearing it again and again.
And I think you bring up a great relationship for those institutions that do have developed sort of their own in-house specialty pharmacy mechanism for those patients to access their medications hopefully more easily, more efficiently. As you said, that creates a deeper connection between the care team and that pharmacy. So that sounds like a great relationship. Sometimes, depending on what the payer requires, you're still having to go to those kind of big box specialty pharmacies. Again, they have good intentions. They're trying to do the right thing. But I think, again, giving those patients that reassurance that if you're ever confused, you can come to us and we can try to provide that clarity. But it does sound like as this has become more commonplace working with sort of outside or even inside specialty pharmacies, trying to kind of create that cadence of like who's talking to the patient and when they're talking to them and when to make sure that we're reconnecting with the patient to ensure that they're clear on what their instructions are and how to take those medications.
I agree. I think that's a really great point.
So I know we've kind of hinted at some of these, but let's focus now on those primary patient education and caregiver education points that we should be communicating to the patient, their caregivers and family about these types of medicines and how they should be taking them.
The first thing I think of when I think of this is adherence. When you talk about adherence, of course, everybody goes to the oral medicines, and that's true. That's very true. But I will tell you adherence to the schedule. A lot of times people are getting LHRH agonist every 3 months. So you know what I mean? Maybe you're going to miss it this month. You miss one dose, that's 6 months. So it's really important that if people are going to not be able to get their injection, that they call and it's rescheduled and to have a mechanism to make sure that you don't lose people to follow up. So adherence to all therapy, essential. I also think another thing is to educate people upfront about the cost of these agents. They're high cost drugs. They almost all are dispensed through specialty pharmacy, not all. And if they go through specialty pharmacy, hopefully you have somebody that helps them with the copay that can be outrageous. And if they can't pay the copay, find a way to help them or think of a different agent. And so sometimes we will pick an agent based on what a patient can pay for through their insurance. The other thing is to look at communication with the team about how they're doing with symptoms, new side effects. And then, of course, my gold standard is a lot of these oral drugs, drug interactions are common. They need to let us know when they start a new medication, whatever doctor gives it to them, whatever provider, and when they're stopping a medication. So I make sure that there's good communication with the team so that we can coordinate their care better. I think these are some of the most hands-on type care issues of the patients I treat. There's lots of people talking to you when you're getting chemotherapy in a clinic, lots of good resources. When you're taking these medications at home, we rely on those patients to come back to us. And we have to kind of create that so that they do it when things change so we can optimize their care.
Absolutely. I think you brought up some great points there, especially about, if the patient is on an injectable medication that does only require every 3-month injections, making sure that they understand kind of what is the cadence of appointments and follow up, any blood work, any other testing in between those visits. And as you said, keeping them on that schedule to maintain the efficacy that they are hopefully getting from that drug is super important. I also appreciate you bringing up the financial piece, and this could certainly be its own probably series on a podcast of just talking through the complexity of that. I remember, and this was years ago, but, a patient just got their prescription and it was a lot of money, but they just assumed that was it and they were figuring it out. They were having to make these financial decisions, assuming that, well, this is the drug I have to get and this is the cost. And so always packaging that upfront discussion of here's the therapy we're recommending. We anticipate that it's going to come back and be expensive. And so depending on what your insurance is and how it's covered, whether it's coming back to the nursing care team, hopefully if your institution has financial navigators or financial counselors that are part of your care team that help kind of take on this piece of the care management, but just making sure the patient understands if that number that comes back is prohibitive, that they need to communicate with the care team. Because as you said, there's usually plenty of, whether it's copay cards or other assistance funds that can help mitigate those costs. And then ultimately, if there's not, as you mentioned, sometimes there's alternative therapies that can be chosen if need be. But just sending that patient off and making them feel as though they're having to figure it out on their own, that's something that when I remember that story, it's like, I would never want to do that again, where patients feel like they just have to be the ones to figure out how to make it work.
I think this is one of the biggest challenges we face today in healthcare. And I think that it takes a lot of time and expertise. And I just really am grateful I work with a team that puts the time into it to help make sure that each patient gets what they need.
Absolutely. It cannot be overstated or overvalued about how important that piece of the care is, especially as treatments and therapies have become more complex and, as you mentioned, more expensive. Just making sure that we infuse that layer of support as much as we do for the clinical support. I think the financial support, it needs to be matched. So how do you see pharmacists and oncology nurses continuing to collaborate to help manage adverse events or toxicities, provide the patient education, and really serve as that trusted source of information for patients that are getting these types of therapies?
It's funny. I can't even imagine providing care without the team I work with. I work with providers and oncology nurses and nurse navigators, and together our responsibilities overlap often, which is, I think, very good. So when somebody's not there, there's somebody to help fill in those things. We do a lot of education. We supplement the education that may be done by, say, specialty pharmacy. We assure patients get their initial dose and that's, okay, this is one of my key things. I want to know when that patient finally gets that initial dose, and I document it in the chart because I want the team member to know when they're seeing the patient, they've been on it for a week or they've been on it for like a month. It's a difference when you're doing the assessment of toxicities. And so just that kind of coordination. The other thing I'm going to say, and this is, again, probably one of my pet peeves, I really believe in communication in real time. So you can document something in the chart, but I will tell you, I don't go look in all my patients' charts to see what's happened in the last month, especially in between visits. I think it's really important as a team to talk. I talked to Mr. Jones today. This is what's going on. This is what I told them. If they call you, just know this is what I told them. But this is where coordination of care becomes essential. And that means also coordination of care with comorbidities that we are not managing. So I know everybody has a different opinion about whether the oncology team manages the comorbidity or if you work in collaboration with the primary care providers. I kind of go with that route. But then that means I call the primary care providers and let them know. I always say to a patient, let them know you're starting this because it may impact your hypertension, your lipids. So those are things I think are some of the ways that we can work together.
Absolutely. I champion your description of just that true team collaboration where it's not about my territory or my realm of work and your realm of work, but acknowledging and appreciating that how and when they overlap is actually to the patient's benefit and not any sort of commentary on me being able to do my job well enough for you. It's like there's going to be times where it's good that they overlap because, as you mentioned, there's always hopefully someone there to address or answer a question. And then just having that additional layer of reinforcement, depending on whoever the patient interfaces with as part of their care management, just knowing that somebody's got your back because you guys are all working kind of towards that same goal. So I agree. Care coordination is the reality for all cancer because cancer is complex and only getting more complex. And so we have to look to our partners and our teammates to understand how our work dovetails together and how we all sort of feed into that machine of making sure the patient gets the absolute optimum care. So Mo, what do you think the future looks like for these anti-androgen or these androgen deprivation therapies in the landscape of cancer care?
I think there's going to be more drugs that are developed that improve upon some of the challenges we have now. I think that there's going to be expanding indications for the drugs we have. So one of the things is when you're picking which androgen receptor antagonist, you may choose it based on what the FDA indication is, because that's what will allow the patient to get it paid for by their insurance. All of these drugs don't have the same indications. And enzalutamide just got a new indication last year that the other two don't have yet. So I see new drugs broadening or expanding indications. And then I hope we have a better understanding how to sequence these drugs optimally to each in patient subsets so we know how best to use these agents. And I think we're going along that pathway, but I keep hoping that it gets even better than what it is now.
Well, Mo, thank you again for joining us once again on the podcast to talk through this very interesting and complex drug class. As we reach the end of our episode, we do like to always go through a kind of our quick fire questions just to help summarize what we've talked about. So to start that off, how do you think healthcare professionals should evaluate their hidden or implicit bias as they approach caring for patients who are taking these androgen receptor inhibitors, antiandrogens, or androgen deprivation therapies?
I hope that they look at things that are important to these men with prostate cancer on these drugs, bone health, sexual function, management of symptoms such as hot flashes. I really hope that those become as important as nausea and vomiting is for all of us.
And don't assume that you know what the patient values because of maybe their age or their relationship status. It's still important to ask those questions. Absolutely. What are some common misconceptions about androgen receptor inhibitors, antiandrogens?
That they're all the same. I think that people don't realize the nuances of these agents in terms of toxicity, definitely in terms of indication and place in therapy.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the long-term toxicities associated with androgen deprivation therapy and the impact on health and how very important that is for our patients that have prostate cancer receiving these agents.
What's additional training or education that oncology nurses need to stay current in this topic?
I'm going to change this. Oncology nurses, oncology pharmacists, and me.
Absolutely.
And I think it is on survivorship issues such as sexual function. I think that this is an area that some people are phenomenally good at, but I think all of us need to be phenomenally good at.
And what are some additional resources for patients or other providers who just want to learn more?
I think that NCCN, of course, is great. I think NCCN supportive care guidelines on survivorship and fatigue give some great resources for some of these hormonal related side effects and fatigue. And so I think those are good resources to use for individual patients.
I love that. We'll be sure to include some links to those in our episode notes for today. Well, thank you again, Mo. We're at the end of our episode. I appreciate all of the knowledge that you bring every time we have you on. Do you have any final comments to share with our listeners today?
No, I really just enjoy talking about this group of agents. They're so logically designed, but there's so much to know about them. And it's been just fun to be able to talk about them with someone who obviously cares as much about the individual patient as I think all people that listen to these podcasts do.
Absolutely. Well, thank you again, Mo.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.